Welcome back, everyone. We're now going to talk about anti-dysrhythmic drugs. So these are drugs that are used to treat arrhythmias or dysrhythmias. There are four classes, class 1, 2, 3, and 4, that we're just going to give you a brief overview of. Now, these drugs are usually used for mild to moderate dysrhythmia. Severe dysrhythmia is usually treated by pacemakers. So if somebody has severe bradycardia, so very low heart rate, then an artificial pacemaker will be inserted. Or if, the severe dysrhythmia is a very severe tachycardia, then electrical cardioversion. So there is this syndrome called Brugada syndrome where patients have an abnormal sodium channel. So it opens when it shouldn't, and that's what leads to ventricular fibrillation. So these people will have a defibrillator implanted internally in their chest because they're, at really high risk of going into VF. Now, many of these anti-dysrhythmic drugs target ion channels or adrenergic receptors. And these adrenergic receptors are what adrenaline or epinephrine or noradrenaline or norepinephrine bind to. And this is how the sympathetic nervous system then regulates heart rate. So what kind of ion channels could be targeted to alter myocardial contraction? Now, I think most people would know that it could be the sodium channel, or it could be the calcium channel, or could be the potassium channel. So just a little bit of revision to begin with in terms of the cardiac muscle cell action potential. We have this sort of upstroke here, which is this depolarization phase where that membrane potential becomes positive for a brief period of time. And that's due to the opening of many sodium channels. So there's that rapid influx of sodium into the cardiac muscle cell, changing that membrane potential and causing depolarization. Then we have this early repolarization phase where some, potassium channels open, some potassium leaves, but then those channels close. We also have these calcium channels then that are open, which allows the influx of calcium into the cardiac muscle cell. And this is what causes that plateau phase, so that lengthening of the action potential to allow for, proper sort of contraction of the ventricles. And then finally, we have this rapid repolarization phase, which is due to the opening of many potassium channels, and, potassium floods out, or there is rapid efflux of potassium from the cardiac muscle cell. We also have the action potential at the sinoatrial node, and this is a spontaneously generated action potential that sets the pace of the heart. And what I need you to know to understand some of these anti-dysrhythmic drugs is that depolarization of the SA node involves the movement of calcium through many voltage-gated channels. So here we're looking at the action potential. We have this pre-potential that forms. Remember, this is a spontaneously generated action potential. So this pre-potential, which is this sort of gradual sort of increase towards, zero in terms of millivolts. And this is due to the movement of sodium ions and calcium ions into the sinoatrial nodal cells. When that reaches about -30 to -40 millivolts, it reaches threshold. And then many voltage-gated calcium channels open. Calcium floods in to cause that really rapid upstroke and that depolarization phase of the SA node. And then we have rapid repolarization through the opening of the potassium channels, and potassium floods out of the sinoatrial node cells. Now, there are many anti-dysrhythmic drugs. There are traditionally 4 classes, and they're conveniently called class 1, 2, 3, and 4. And some anti-dysrhythmic drugs don't fit neatly into the 4 classes. Class 1 target sodium channels, class 2 target the beta-adrenergic receptor, class 3 target potassium channels, and class 4 target the calcium channel. So you might want to think of a little mnemonic sort of to help you remember this. So if you think about sodium, it's Na+, class 2, B, so B for beta, class 3, K for potassium, and class 4, C for calcium. So you end up with N, B, K, C, and so you could say never beta kettle chip. So that's a good little way to remember the 4 classes. You can come up with your own mnemonic, but that's my one. So we'll start with the class 1 antidysrhythmic drugs, and these block voltage-gated sodium channels. Now, these drugs bind to sodium channels best once the channels are open, so during depolarization, or are in the refractory period. So they decrease the maximum rate of depolarization and increase the time required to activate the channels again, because they're binding to the channels when they're in the refractory period. Now, this is where they get really cool. The more often the channels are activated, so become open, the more likely the drugs are to bind to the channels and inhibit them. And it's for this reason that these drugs won't inhibit the heart from beating at normal frequencies. So these class 1 antidysrhythmic drugs will inhibit high frequency excitation, and they're used to treat tachycardia and tachyarrhythmias, and some are also used to treat some types of fibrillation. So by blocking the voltage-gated sodium channels, they decrease the heart rate. Now, post-myocardial infarction, there's usually increased sympathetic nervous system activity. So what problems do you think this might cause? So let's have a look at this on the next slide. Right, so we're talking about post-myocardial infarction, increased sympathetic nervous system activity, which will increase the heart rate and increase ventilation. Overall, the net effect of increased sympathetic nervous system activation is to increase vasoconstriction, which will lead to increased blood pressure and therefore increased peripheral resistance. And that will cause increased workload on the heart, which is the last thing that you want. The person has had a heart attack due to the cardiac ischemia. There's already, decrease in blood flow, and now you've got increased workload on the heart, and that will sort of exacerbate the situation and cause increased tissue damage. So these class 2 antidysrhythmic drugs are given post-myocardial infarction to decrease that workload on the heart by decreasing the heart rate. So as previously mentioned, these class 1 antidysrhythmic drugs are used to inhibit tachycardia and some types of fibrillation. And exactly which drug is used depends upon its subclass. So there are different subclasses, and we don't want you to know anything about them. So you don't need to memorize these examples in blue. But class 1A may be used to block atrial fibrillation triggered by vagal overactivity. Class 1B may be used to treat or prevent ventricular tachycardia and fibrillation during and immediately after a myocardial infarction. Class 1C may be used to treat recurrent tachyarrhythmias caused by abnormal conduction pathways. Now, you do need to know this. Sodium channel blocking in the nervous system will cause anesthesia, and some class 1 antidysrhythmic drugs are also used as local anesthetics, for example, lidocaine. And if you go on to study more about local anesthetics, particularly students enrolled in podiatry, you'll learn lots more about lidocaine. And we did kind of talk about it way back in topic 3. And unwanted side effects then can include effects on the central nervous system, such as drowsiness and disorientation. Now, also, there are a wide variety of class 1 drugs with a wide range of specific pharmacokinetic issues and unwanted effects. So we're not going to go into all of those here either. But one example is that drug lidocaine. It is often used post-myocardial infarction. It's rapidly metabolized by the liver. It can't be taken orally, so it's administered intravenously, and it does have effects on the central nervous system. What's really important when using lidocaine is that hepatic blood flow is important for determining the dose. But here, it's often used post-myocardial infarction where blood flow is low, to begin with, and cardiac output is, often decreased. So as a result of this, there's poor blood flow to the liver, and therefore that can cause the lidocaine to accumulate and toxicity may increase. The second class then are the beta-adrenergic receptor antagonists, also more commonly known as beta blockers or beta-adrenoceptor antagonists. Now, I think everybody knows knows what an antagonist drug is at this stage. It's a drug that blocks the binding of the endogenous ligand. And what we're talking about here are the beta adrenergic receptors that are found in heart tissue. Now, what I need you to think about is the neurotransmitter norepinephrine or noradrenaline will bind to the beta adrenergic receptor. Also, the circulating hormones noradrenaline and adrenaline will also bind to this receptor. Now, there are two different beta adrenergic receptors in the heart, the beta 1 and the beta 2. We're really talking about the beta 1 here that norepinephrine released from sympathetic nerves and binds to increase the heart rate. Circulating hormones in the bloodstream also bind to the beta 1 adrenergic receptor to increase the heart rate as well. So these beta adrenergic receptor antagonists are competing with those endogenous ligands for the binding site, and in doing this they're going to decrease the heart rate. So because of this, these beta adrenergic antagonists are therefore sometimes used post myocardial infarction. And the beta adrenergic antagonists can also be used to prevent tachycardias caused by sympathetic nervous system overactivity in other situations. For example, with paroxysmal atrial fibrillation. And I've just written there, what does paroxysmal mean? In terms of the AF here, it means a sudden exacerbation of the atrial fibrillation. These drugs, of course, can have their own sort of unwanted effects too, and this can include effects on the respiratory system. So what do you think these effects on the respiratory system may be, given that we've just done the respiratory system and we looked at how, the beta 2 agonists can be used for people with asthma to cause bronchodilation. Here you're using a beta 2 antagonist, so they're going to cause bronchoconstriction, some of them. So there is an increased risk for asthmatic patients in taking some of these class 2 antidysrhythmic drugs. And it can be difficult to get the dose right, so sometimes these drugs work too well and they reduce the heart rate too low. So bradycardia and fatigue are also common unwanted effects. Moving on then to the class 3 antidysrhythmic drugs, these drugs substantially prolong the cardiac action potential. They increase the refractory period, and this involves blocking some of the potassium channels involved in repolarization. So by prolonging repolarization, you're also delaying the next depolarization, and that's what's going to decrease the heart rate. However, this shows up as a prolonged Q to T segment on an ECG trace, which I'm just pointing to here. And these are the drugs that can cause that torsades du pointe arrhythmia that I mentioned in the previous recordings, where you get that kind of pivoting sort of around that isoelectric line that sort of resembles a ballet move. And they can be used to treat tachycardias and ectopic beats. And I think everybody knows what an ectopic beat is at this stage. It's those isolated contractions that are, independent of the electrical conduction system. These drugs are powerful antidysrhythmic drugs. And if these drugs prolong action potentials too much, they can actually cause dysrhythmias, and ironically, that does include tachycardia. So they shouldn't be used in combination with other drugs that prolong the action potential, such as antipsychotics. They shouldn't be used by people who have abnormal levels of electrolytes involved in repolarization. So what two electrolytes are principally involved in repolarization? Well, obviously, it's the calcium ion and the potassium ion. So electrolyte levels need to be measured frequently, and they shouldn't be used by people with hypokalemia and hypercalcemia. Now, this makes sense. If you think about hypokalemia, it's, abnormally low blood potassium levels. Now, if this is the situation, you're going to increase the gradient between intracellular potassium will be much higher than the extracellular potassium. So as a result of that steeper gradient, you're going to get more, potassium leaving the cell in depolarization, and that's going to prolong the the action potential just too much, right? Similarly, hypercalcemia is a high blood calcium level, so therefore you're going to increase the gradient, the other way. So too much calcium in the blood compared to inside the cell is going to cause more calcium to flow in and prolong that plateau phase. And again, prolonging the plateau phase is going to prolong the action potential too long as well. The final class then is class 4 anti-dysrhythmic drugs, and these are acting on voltage-gated calcium channels in cardiac muscle cells, at the plateau phase, and also the depolarization phase of the sinoatrial node. So they're blocking voltage-gated calcium channels. So they're going to act upon the sinoatrial and AV node to slow down electrical conduction and therefore decrease the heart rate. Because they also act, at the plateau phase in cardiac muscle cells, they're going to reduce the force of contraction by blocking those calcium channels. And so they can be used to suppress premature ectopic beats. An example of a drug is verapamil. They can't be used for ventricular dysrhythmias, and that's because they're acting on the SA node and the AV node. And they're often used to treat supraventricular tachycardia, so that's tachycardia originating in the atria, and to reduce ventricular contractions in people with atrial fibrillation. So as I just said, supraventricular means above the ventricle, so in the atria. So this tachycardia means an increased heartbeat originating from above the ventricle, so in the atria. So by changing the conduction originating in the atria, you can therefore decrease the rate of ventricular contraction. So the ventricles are contracting really rapidly, but if you treat the origin of that, which is the supraventricular tachycardia, then that's going to decrease the rate of ventricular contractions too. So the symptom is increased ventricular contraction. The underlying problem is in the atria, not the ventricles. Bradycardia is a risk with these drugs too. And some compete with the cardiac glycosides such as digoxin, which we're going to talk about next, which is a drug that's used to treat heart failure. And they compete with these for tissue binding sites and inhibit their excretion by the renal system. So this is a pharmacokinetic interaction, and it can increase the plasma levels and toxicity of the glycosides, for example, when there's co-administration of verapamil and digoxin. Okay, so this is just an overview of everything that I've been talking about. It is from Rangendale. I have put in an extra little arrow here. If you look at the textbook, you'll see that that's not there. But what we started talking about first was the class 1 anti-dysrhythmic drugs that block those sodium channels, and so therefore they decrease that maximal rate of depolarization to decrease the heart rate. Then we talked about these class 2, so the beta adrenergic antagonists that are acting to decrease heart rate. Then we looked at the class 3, and they're the ones that are blocking those potassium channels to therefore, prolong repolarization and therefore prevent the next depolarization to treat, to decrease heart rate. And then we finished up just a minute ago, just looking at the class 4 ones. And these ones act at the plateau phase of cardiac muscle cell to decrease the force of contraction. But they also, act on the SA node and the AV node as well to decrease heart rate. So I'm going to finish here, everybody. And when I come back, I'm going to be talking about the cardiac glycosides, in particular digoxin.